everyone. I appreciate everyone coming today. Today I'm going to be doing a presentation on total body cooling. If you have any questions during the presentation, please feel free to raise your hand and ask questions. So it is cold in here is our theme for today. Objectives. We're going to establish risk factors for HIE. We're going to go over the pathophysiology of HIE, the initiation of total body cooling, some side effects of body cooling, and outcomes of body cooling, the future of body cooling, and we're going to ask questions, please, throughout the entire thing. If you have any questions, feel free to interrupt. And then there's going to be a short post-test afterwards. These are some definitions that I would like for you to be able to differentiate between. Hypoxia is body or part of the body deprived of oxygen. Hypoxemia is diminished oxygen in the blood supply. Anoxia is complete deprivation of blood supply. And ischemia is diminished blood supply to the brain. Asphyxia is a lack of oxygen in respired air resulting in hypoxia and hypercapnia. These are all very close and related to each other, but I'd like for you to be able to tell the difference. Risk factors of HIE. Antepartum risk. Maternal thyroid disease, PIH, fetal growth restriction. Intrapartum risk include maternal fever, OP presentation, cord compression, uterine rupture, abruption, intrapartum hypoxia, abnormal fetal heart rate, meconium, low Apgars. All these things can be a setup for HIE. Other causes from a baby standpoint include metabolic disorders, hypoglycemia, congenital brain anomalies, and injuries from birth trauma. Some examples are on these pictures here. Vaginal delivery is always a risk factor, and vacuum delivery is a risk factor. So how often does HIE occur? Hypoxic ischemic encephalopathy affects 1 to 3 per 1,000 live births in the U.S. a year. Until the development of hypothermia, the treatment was aimed at supportive care with mortality rates of 10 to 60%, with survivors' morbidity rates of 25%. 15 to 28% of CP is a result of HIE. So those are not great statistics. Encephalopathy. Neonatal encephalopathy include one or more of the following: abnormal neurological exam, altered consciousness, abnormal muscle tone or reflexes, altered respirations, and seizures. And these can be caused by perinatal asphyxia, intracranial bleeding, and stroke. The definition of HIE, as established by Cotton and Shankaran, states that HIE is defined as brain injury caused by a combination of inadequate blood flow and oxygen delivery to the brain. So what does it cause? Some long-term effects: death, CP, epilepsy. Some immediate effects that we'll see from 7 to 14 days include seizures, hypotonia, poor feeding, altered level of consciousness. The pathophysiology. It is simplified into 2 phases: primary energy failure and secondary energy failure. These phases can manifest weeks to months to years after the event. Breaking down the insult. So initially there is an insult, and the primary energy failure is the first stage. And then there's a brief period where the body recovers and stabilizes and reperfuses and reoxygenates. And then that only lasts a very short period of time, and then we go to secondary energy failure. So what areas of the brain are affected? The deep gray matter areas are the most affected by HIE. The white matter is generally spared. Cerebral blood flow in infants. Cerebral blood flow is different in babies than it is in adults. Adults remain constant despite systemic blood pressures, whereas in infants, cerebral blood flow does not adjust as well. During hypoxia, the initial systemic response is to perfuse the brain and other organs through redistribution of cardiac output by increasing heart rate and epinephrine release. So we are going to perfuse the organs that are most important to us: the heart, we're going to perfuse the brain. However, the baby can't hold this up or can't keep this process going for too long, and that's when apoptosis occurs and damage to the brain starts occurring. So primary energy failure. This is the reduction in cerebral blood flow, which impedes oxygen and substrates to the brain tissue. This is the phase when brain tissue acidosis is prominent. Causes acute intracellular derangements, including loss of membrane ionic homeostasis, release and blocked reuptake of excitatory neurotransmitters, defective osmoregulation and inhibition of protein synthesis, which ultimately causes increased intracellular calcium. Calcium activates lipases, proteases, and endonucleases, which cause cell death and necrosis. I will break that down for you and make it a little bit simpler. So, primary energy failure may recover with reoxygenation and reperfusion, but only to give way to secondary energy failure. Okay, so let's break down what I just said. Simple is better, so we have an insult. This decreases our oxygen flow to the brain. It decreases our glucose that's available to the brain, which leads to our primary energy failure. Anaerobic metabolism starts to occur, and this is where lactic acid builds up and it leads to free radical production, which is going to cause damage. Okay? So let's look at this again. We have our free radical buildup now, and anaerobic metabolism leads to depletion of high energy phosphate reserves. So it's going to, anaerobic metabolism takes a lot more energy if you're remembering your biology and chemistry. It uses ATP, and it's a lot harder to create glucose and oxygen that way. So as a result, we're going to increase our sodium, calcium, and water. And this releases of glutamate and excitatory neurotransmitters, which are going to ultimately cause damage. Anaerobic metabolism leads to less glucose for the brain. Secondary phase begins around 6 to 15 hours. This is not an exact science. The insult could have started from any time while the mom was carrying the baby, as mom abrupted. It could have started 3 hours before delivery. So this is not an exact science, but through research, they feel that our window of opportunity is from 6 to 15 hours, and we try to get a baby on the blanket by 6 hours. So there's a brief restoration before the secondary phase begins, and that's when our pH, our vital signs, and everything stabilizes. There's absence of seizures. And then our clinical deterioration starts to occur and our secondary phase begins. Secondary energy failure is influenced by the amount of primary energy failure damage. And this phase does not include brain tissue acidosis. This phase is not as well understood, but ultimately leads to altered growth factor and protein synthesis, which adds to the insult of altered brain development. And our result is HIE. Both phases ultimately lead to apoptosis, which is cell death. Now, the brain naturally has apoptosis that occurs. However, when apoptosis occurs at an accelerated rate and in parts of the brain that we don't want it to occur in, that's when cell damage occurs and brain damage. So there's a latent period between the primary energy failure and the secondary energy failure. The time of reperfusion, what I was talking about, and stabilization. This is our window of opportunity to prevent the brain damage. So this is when we need to get our baby on the cooling blanket. Why does hypothermia work? When cooling is initiated, it slows apoptosis. Decreases in brain temperature by 1 degree Celsius decreases energy utilization by 5%. The decrease of energy utilization increases neuroprotection and enhances the maintenance of high energy ATP during HIE. Cooling normalizes protein synthesis, which reduces free radicals. Cooling reduces excitatory neurotransmitter glutamate. So why hypothermia? Clinical studies have shown that a reduction in mortality and reduction in disability in infants with HIE when cooling is initiated within 72 hours of life. So we have some research to back up why we're doing this. Let's go to the other extreme, which is hyperthermia. Hyperthermia and pyrexia cause the opposite effect of hypothermia. We want to avoid this at all costs. My take-home message here, do not overshoot for temperature. Monitor your temperatures. When you're waiting for the baby to go on a cooling blanket, make sure you monitor those temperatures and we're not getting this baby hot instead of cold. Cooling. The body can be cooled in 3 ways. Head cooling, body cooling, head and body cooling. Head cooling is the cool cap. Here's some pictures of the cool cap. I know we don't use that here, so I thought you guys might want to see what it kind of looks like. And here's a picture of the total body cooling where they're using the Blanketrol, as you can see, and that is what we use here. So let's compare the two, total body cooling and head cooling. Total body cooling is a systemic cooling system. Head cooling is head and systemic. There's a little bit difference in the temperatures. Total body cooling gets the temperature to 33.5 degrees Celsius core temperature. The core temperature of head cooling is usually 34 to 35. Not quite as cool in the core part of the body, however cooler at the head. The core site for temperature monitoring for total body cooling is the esophagus. And the core site for temperature of head cooling is the rectal temperature. There's a little bit of difference in the time that it takes to achieve the core temperature. With total body cooling, it takes about 1.5 hours. For head cooling, it takes about 2 hours. And both are done for 72 hours. And rewarming is at 0.5 degrees Celsius an hour. Okay, so why did we choose total body cooling over head cooling? Whole body cooling cools the brain homogenously, which means it cools all the brain, including central and peripheral brain mechanisms. Head cooling provides cooling to the periphery of the brain, more than central cooling of the brain. Now, with this being said, research has shown that the inner part of the brain correlates well with the core body temperature. So what we believe is if we get our core body temperature down to 33.5, we are cooling the innermost part of the brain to 33.5, which is our goal. Okay? HIE generally causes trauma to the central parts of the brain, so whole body cooling was chosen to ensure we achieve central cooling within the brain. Okay. Inclusion criteria. They need to be 35 weeks gestation or more. Cord or baby blood gas with a pH of less than 7 or a base deficit less than 16. And a history of an acute perinatal event and or a 10-minute APGAR of less than 5. Need for mechanical ventilation and moderate or severe signs of encephalopathy and diagnosed seizures. This criteria has been established by many evidence-based trials. We have based our inclusion criteria on all the trials that have been carried out in the past, so that's where we come up with this. Some exclusion criteria. If the baby is greater than 6 hours of age, they don't get cooled. If there are major congenital anomalies or chromosomal anomalies going on, we don't cool those patients either. Here's the modified Sarnet stage. This is how we're going to decide if it's mild, moderate, or severe encephalopathy. This is our neurological exam. So we're going to look at this closely to determine at what point of encephalopathy we are at. Passive cooling. I want to mention this because when we're in an interim and the baby is up in the delivery room and we're thinking, oh, this has been a terrible delivery, we might need to cool this patient. Well, there's a time period before we decide that we're cooling. And while we're waiting, we don't want to overheat this baby. So passive cooling is the best way to go. Passive cooling is usually achieved by turning off the radiant warmer. Our goal temperature to cool is 33.5 degrees Celsius. What you need to realize is that these babies cool very fast. You don't have to do anything but by convection and evaporation, the baby is going to cool very, very fast. You need to monitor temperatures very closely. Our goal temperature while passive cooling should be 34.5 to 35.5. We don't want to get below that yet. So, you may require heat, and it's just important to monitor those temperatures and not let it get too low. Initiation of total body cooling. We've decided we're going to cool the baby, so what are we going to do? We have to start this before 6 hours of age. We're going to set up our blanket roll. We're going to have an esophageal probe inserted. We're going to get out our necessary labs. We're going to obtain an EEG. And we're probably going to have a UV and a UAC placed. Before we put the baby on the blanket, we need to obtain our EEG. The EEG machine will not pick up if the baby is already on the cooling blanket. Artifacts, there's too much artifact and it does not pick up. So just keep that in mind. We're going to obtain our normal labs. We're going to obtain a head ultrasound. And we're going to get chest x-ray to verify that our esophageal probe is truly at the core where we want it. We use the blanket roll 3 here. And we are going to obtain a small blanket that's 24 to 30 inches. We need to check all the necessary water levels, the black tubing to make sure they're connected. And then we're going to power on the machine. Now, esophageal probe placement. To place this, we are going to measure from the tip of the nose to the xiphoid process and subtract 2 centimeters. Nasal placement is preferred, however, you can put it in orally if needed. We are going to confirm placement by chest x-ray. The probe does not have numbers on it, so we need to be sure that we mark this tube with a black marker. So we don't dislodge. If it does become dislodged, we know that. Only after it has been confirmed by x-ray that it is in the correct position. The cooling phase. Now we've got the baby on the blanket. Between the baby and the blanket should be a pillowcase and nothing more. No developmental items should be in the bed with the baby. This is going to cause heat trapping, and we are trying to cool the baby, not heat the baby. If you do want developmental rolls, you can put rolls underneath the blanket just to contain the baby. But you need to make sure the blanket is still next to the baby, because our goal is the maximum body surface area in contact with that blanket. And our goal temperature is 33.5. Once we get to 33.5, we're going to set our pressure gradient at 10 degrees Celsius to make sure that our temperature does not go above 34 degrees Celsius or below 33 degrees Celsius. The blanket is going to warm and cool to keep our baby at the 33.5 degrees Celsius that we desire for 72 hours. This process begins as soon as the baby is placed on the blanket. Temperature may not have been reached yet, but the 72 hours has begun. And as you all know, it doesn't take very long to get to that to the 33.5 temperature that we're shooting for. We're going to get a multitude of labs. Here's a run through of your 6-hour, 12-hour, 24-hour, 48-hour, and 72-hour labs that you will obtain. When we rewarm, this phase usually begins at 72 hours. So we're going to start increasing the temp by 0.5 degrees Celsius every hour until we reach a core temperature of 36.5. When the patient's temperature reaches 36.3, we can just monitor. This whole phase usually lasts about 6 hours to get back to core temperature. What are we going to watch for during rewarming? There's a lot of things going on with hemodynamics whenever we are rewarming this baby. So a lot of things can happen. For example, apnea can occur. Hypertension may occur. Our intravascular blood volume is increased, so it's going to cause some changes. Okay, our patient's warm. Now we need to put a skin probe on the baby and turn on the radiant warmer. Use servo control and monitor temperature. Do not allow temperature to exceed 36 degrees Celsius. Continue to monitor esophageal, axillary, and skin temp every 30 minutes until the goal temperature is reached. And we're going to monitor core temps for 4 to 6 hours post-warming, okay? Okay, so we've done all this. Now what do we document? Well, we need to document for the first 4 hours, the temperature should be measured every 15 minutes, okay? As this is the 4 hours that we're trying to reach our core temp. And for the next 8 hours, we're going to measure the temperature every hour. And then we're going to measure the temperature every 4 hours during the maintenance period. And we want to document heart rates, blood pressures every hour for 12 hours, and then every 4 hours after we are rewarmed. And we're going to assess skin integrity and reposition every 6 hours. Every 6 hours, this baby should be turned, every 4 to 6 hours. And I'll tell you some complications that can happen if we don't move this baby around some. Rewarming phase. We're going to document temperatures every 30 minutes until the temperature of 36.5 is met, and then we're going to document temperatures every 4 hours. Let's talk about some of the side effects that can occur with total body cooling. Total body cooling affects the platelet function. It can cause subcutaneous fat necrosis, renal and hepatic alterations. It alters the heart function, and it affects medication absorption. So let's first talk about platelet function and total body cooling. Bleeding problems during hypothermia are uncommon. However, there has been some bleeding documented in trials and research, so we're going to talk about them. Some bleeding problems include pulmonary hemorrhage, bleeding at puncture site, intracranial hemorrhage, which has been very rare, only documented like once, but it can happen, so just keep it in mind. Bruising, oral and gastrointestinal bleeding. Impaired platelet function. There are two mechanisms that are responsible for impaired platelet function. The endothelial dysfunction in the cold extremity impairs the initiation phase of platelet plug formation. Platelet granule release, which makes platelets less capable of adherence during the phase of plug formation. So what this is saying is our body's cold, and it's going to delay the release of our platelets, number one. And then when the platelets get there, they're not going to want to stick together. Okay? Increased bleeding times. Bleeding time can also be influenced by other factors other than cooling, such as ampicillin increases bleeding times, asphyxia increases bleeding times. So as we know, our baby who's cold is asphyxiated, and it's going to be on antibiotics. So it's got 3 strikes against him, so our bleeding times are going to be increased, okay? It's not totally clear that cooling is solely responsible for increased bleeding time and impaired platelet function, but this is definitely a phenomenon to expect during cooling, okay? So nursing considerations for impaired platelet function. We're going to obtain a PT, which is a prothrombin time. Normal prothrombin time is 11 to 15 seconds. We're going to expect ours to be a little bit longer than that. We're going to get a PTT. That is a partial thromboplastin time. And this is the time it takes for a clot to form. Normal times are 35 seconds. We're going to expect ours to take a lot longer. Okay? We can anticipate some platelet transfusions. The platelet function is expected to return to normal once the patient is warm again. Subcutaneous fat necrosis. This is what can occur, not just because of not repositioning, by the way. Repositioning is important, it helps prevent this, but it's not to say that this will not occur. It is caused because infants have higher saturated to unsaturated fat ratio in their subcutaneous fat, which tends to crystallize when cooled. It presents as a red nodules on the back. You can see them, you can feel them. And it usually goes away in a couple weeks after the patient's warm again. This usually occurs after during the first week of life. It doesn't necessarily have to happen while your baby is being cooled. It can happen afterwards. This is something you want to assess for if you know that your patient has been cooled in the past. Complications from this subcutaneous fat necrosis include pain, scarring, development of abscesses, subcutaneous atrophy. It's caused by blood shunting to the brain and the heart and the adrenal glands. It's going to all those most important organs like we discussed before, and therefore not to the skin. So if the skin is not getting perfused, guess what? This is what's going to happen. So decreased circulation leads to inflammation and necrosis of the fat tissue. Treatment. Subcutaneous fat necrosis usually resolves spontaneously in a couple of weeks. The byproducts are reabsorbed and liquefied. But we're going to watch for some signs of failure to thrive, vomiting, and lethargy. And this is going to be due to hypercalcemia. Weekly calcium levels need to be followed until the fat necrosis actually resolves. The fat necrosis, while it's being reabsorbed, actually creates more calcium, so that's going to lead to the failure to thrive and vomiting. Heart effects. All cooling studies have documented sinus bradycardia during the cooling period. So expect a low heart rate. Cardiac output and stroke volume are decreased during the cooling period. And what controls cardiac output? Heart rate. Heart rate controls cardiac output. So a decreased heart rate, decreased cardiac output. Hypotension can occur. Prolonged QT intervals have been documented. And all of these symptoms will go away when the patient is warm again. Nursing implications. We are going to manage this hypotension with vasopressors, inotropes. We're going to give blood products. Renal and hepatic alterations. Renal and hepatic blood flow are diminished during cooling. It causes decreased elimination of medications. Monitor for drug toxicity. This phenomenon may decrease the need for large doses of antibiotics, anti-seizure medications, and sedation. Some renal effects. We're going to have a decreased GFR, impaired water and salt reabsorption, decreased potassium. Potassium is going to be moving into the cells, so serum potassium will be lower. Decreased calcium, magnesium, and phosphorus. Nursing implications. Expect to place a urinary catheter. We're going to need to monitor urinary output very closely at this point. We're going to monitor for hypovolemia and decreased cardiac output, because that may be causing our decreased urinary output. Monitoring the urinary output helps to recognize inappropriate antidiuretic hormone secretion and avascular tubular necrosis. And this can be a result of the HIE event, not necessarily because of cooling, okay? Affects medication absorption. During total body cooling, babies receive a lot of drugs. We're going to give them sedatives, analgesics, anti-epileptic medications, and antibiotics, all of which are going to be, the pharmacokinetics and the pharmacodynamics of these drugs are influenced by cooling and multi-system failure. So evidence-based dosing guidelines are lacking at this time. However, there are studies that are being conducted right now to hopefully, help us develop some guidelines on how much medications we need to give and when we need to give them. And here's a couple of medications, and it's just a thought process. If you're given morphine, it has increased serum concentrations in the blood and decreased clearance when the baby's cooling. So we could consider giving a lower dose or starting at a lower dose. Fentanyl is the same way. We might want to consider starting a lower dose for it, and also monitor for increased response during rewarming. When the baby's getting rewarmed, we might require a little bit more fentanyl than we did while the baby was being cooled. Phenobarb is the same Gent. We might want to monitor our drug levels, get some troughs on our Gent, decide if we need to space out the dose a little bit farther than we normally would. Phenobarbital. There is a trial that has been done that hypothesized that there would be a more rapid fall in temperature during the initiation of hypothermia among infants given phenobarb before cooling when compared to infants that did not. And this study did support that temperatures did fall more rapidly when the infant was loaded with phenobarbital. And they suggested that it may be due to a reduced metabolic rate and thermogenic response associated with the use of barbiturates. Phenobarbital reduces the brain metabolic rate within 10 to 15 minutes when given at 10 to 15 milligrams per kilo. I will say that other research hasn't necessarily supported this, but they haven't really been focused on that one entity, and this study did focus on that. So it's something to kind of keep in mind. If you're loading your baby with phenobarb, they might reach their core temperature a little quicker than you thought they would. Those affected by HIE and what to monitor. Okay, so we're to the point where we're after the mats are warm, and what are we going to watch for? They're going to have eye exams. Cortical visual impairment may improve with time, and with proper follow-up. So if there are some eye problems, it may improve. If PPHN accompanies HIE, the child is at risk for late onset hearing loss. Epilepsy develops at 3.5 years of age, and 10% of neonates affected by HIE. So keep that in mind. Head circumference is our baseline, and it's important for future comparison. For example, if the baby was born and the head was below the 5th percentile, we'll say the head circumference is below 5th percentile. Well, whenever the baby comes back for follow-up, if it's still below the 5th percentile, it doesn't necessarily mean it's HIE. There might have been an underlying cause there. If the head was a normal size, and we come back for follow-up and we're falling below the 5th percentile, well, maybe we've got some brain damage going on and we need to investigate. Newborn with HIE who are feeding adequately on discharge. There are two groups, okay, of HIE encephalopathy. We've got the stage 1 and then we got the stage 2. Stage 1 is our hyper-alert group and hyperexcitability with no hypotonia. They can come back for regular follow-up if we don't see any other need to keep following them. They're where they need to be. They just need to keep going for their regular appointments. Now, if the hypotonia persists and we are stage 2 or stage 3 encephalopathy, then follow-up is going to be indicated, and we're going to be going to developmental clinics. And key points to remember there is we're going to be watching for adequate feeding and nutrition, head growth, visual awareness, motor development. And they're going to probably need to be followed at 8 months, 12 months, 24 months, 3 to 5 years, and some even 8 to 10 years. So it is a long process. Let's talk about some directions our research has taken. There is evidence and research that has been done in adults. Now, this doesn't apply to us, but we do use this to gauge our own research. And this evidence shows that there is decreased systemic clearance of drugs in the body, which we've already talked about. And there is a research project being done, a study being done right now to develop guidelines for dosing. Toxic analgesic effects due to slow clearance may interfere with neurologic evaluation post-rewarming. So we need to keep that in mind. Whenever the patient's rewarmed, they got a lot of medicines that might be affecting their neurological status. So we need to remember to follow up on our neuro exams. Studies have not been done on the toxicity of antibiotics, but there is a study that is currently researching this phenomenon. So this study is the future of our therapy. Okay, so questions that are being addressed in future research as well that we want to think about. Should we cool a baby that has arrived from a referring hospital and seems to be neurologically improved before cooling? Let's say we went to Camp Lejeune and got a baby. The baby arrives here and is now extubated, looking around, acting pretty appropriate. Should we still cool this baby? We don't know, but they're still investigating this. What should we do with infants that cannot be transferred before 6 hours to initiate cooling? Like I said, the primary energy failure is not an exact science to how long that lasts. Our window could be 6 to 15 hours. However, most research right now is supporting 6 hours. We want to get the baby on the blanket by 6 hours, but what if we're wrong? Is it wrong for us not to cool these babies? That even though it's 7 hours? Who's to say? So we're still looking into that. What should be done with babies that exhibit HIE in the first days of life? So we're a couple days into life and the baby has a hypoglycemic or a metabolic issue. Maybe they're going to exhibit HIE. Should we cool these babies? I don't know. So these are things we're working on. Some other research questions. How do we safely facilitate hypothermia at referring hospitals and during transport? There is active cooling on transport. We currently use passive cooling for transport. However, we usually don't have any trouble reaching our core temperature on transport by passive cooling. Active cooling is usually done with cool packs. However, is this safe? We don't know yet. What are the optimal cooling systems to control temperatures? Is the cool cap better than the Blanketrol? Is the Blanketrol better? Is whole body cooling better? We don't know, but we're still researching that, and statistics are supporting both. Both have good outcomes. Is hypothermia beneficial for patients with mild encephalopathy? So we call moderate to severe encephalopathy. Why not mild encephalopathy? Should we? This is another question. Is hypothermia effective if initiated within 6 to 12 hours of age? So these things are still being researched. So what does the evidence-based trials tell us right now? They tell us that total body cooling reduces the risk of death or disability and increases the rate of survival free of disability at 18 to 24 months. It said that moderate to severe CP was shown in 30% in control groups and 19% in hypothermia groups. So that's awesome. We made a great stride there. Blindness has been shown in 14% of infants in the control group versus hypothermia group, 7%. Hearing impairment has been evidenced in 6% versus the 4% in hypothermia group. So these are good statistics, and we're doing good. Hypothermia for preterm babies. We've, studied hypothermia in term infants, but there was a small trial that was trying to look at hypothermia in preterm babies, and they were trying to decide if it was beneficial for preterm babies with NEC to cool them. This was a very small trial, and I will say that the results were very promising. However, it was very small. The pilot study conducted showing 3 patients died in the controlled group, whereas only 2 died in the cooled group. This is promising, and it will go further. When we initially started cooling term babies, it was a small pilot trial just like this. So who knows? This may be our future. We may be cooling small kids that have NEC. So major clinical trials that support total body cooling include the TOBY trial, the CoolCap trial, and the ICE trial. These are some of the biggest trials that have been done. And the meta-analysis of these trials concluded that there was a significant reduction in the risk of mortality, moderate to severe neurodevelopmental disability, cerebral palsy, severe visual deficit, cognitive delay, or MDI psychomotor delay. And one concern that we have is that we might reduce withdrawal of support and create more severe disability with this intervention. That was a concern going into this. This meta-analysis actually supported that there was no difference in the risk of withdrawal of support between groups, and neurodevelopmental outcomes were improved in survivors. So this is promising and good. It's saying that we are not creating more handicapped people, or we're still withdrawing support when necessary, when we feel there's no hope and the risk outweighs the benefits, and the ones who are surviving are actually having better outcomes. Any questions? I really appreciate everyone coming, and we are going to take a quick post-test, and it's only 10 questions, not a big deal, but if you have any questions, please ask me. Thank you so much for attending.